Okay, I think everyone has joined now. And I'm extremely happy to be able to welcome two Davids to this webinar. We have David Putrino and David Systrom here, and who's going to talk a little about their own research and then put it into a larger context for us. If you have questions for them, please put them into the Q&A and we'll keep an eye on it and we'll answer as many questions as possible. And we will, if there are many questions, we may try to combine ones that are similar. So, but we'll try to answer as much as possible. So the webinar will take about 1 hour. It is being recorded and we'll put it up on YouTube and on Facebook as soon as we have it edited and ready. So then, David Putrino, I think you're first.
Sure, absolutely. Thank you so much for having me here. It's always a pleasure to be chatting with this group. Today, the work that I wanted to share was really focused on all of the clinical trials that we're currently working on, and the caveat that I will share with this is that as I present to you this sort of flowchart of all the clinical trials that we're working on at the core, which is the Cohen Center for Recovery from Complex Chronic Illness, which is our center that treats long COVID, ME-CFS, chronic tick and vector-borne illness, and other associated chronic conditions such as chronic tick and vector-borne illness. The one thing that I really want to share is that we always have more trials coming. So these are some of our active clinical trials, but we also have other ongoing clinical trials that will soon be added to this list. But I just wanted to show the diversity of trials because I really wanted this presentation to be about our firm belief that many infection-associated chronic illnesses have complex drivers. Not everybody will have the same driver of symptoms. And so what we're trying to do as much as possible is create a clinical trial strategy that is addressing many different drivers. So to that end, I'm just going to share a few of them. I'll start off by talking about Humanity Neurotech. This is a really exciting clinical trial that is first in humans. So this is a device that has never been used before, and it's the first of its kind, that uses micro-Tesla magnetic therapy to reduce neuroinflammation. In animal models, the data on this was incredibly compelling. The use of small magnetic currents to change the distribution of and flow of inflammatory cytokines and boost mitochondrial function in the central nervous system was very, very clear. So we have been, our first clinical trial that has been industry sponsored by the company that makes this device is in folks with long COVID who have moderate cognitive impairment. It's a placebo-controlled trial. We're still recruiting, and our recruitment goal is 30 participants, and we have now completed, or we have 25 active participants in the trial. So we're almost done on this. We're very much hoping that we will have results on this by the end of the year or Q1 of next year. Very exciting stuff. Vagus nerve stimulation. I know that vagus nerve stimulation is a hot topic for a lot of people who live with chronic symptoms as a result of long COVID, ME-CFS, chronic tick and vector-borne illness. So what we were targeting here were people with long COVID and dysautonomia. This is a placebo-controlled, randomized controlled trial. We have actually completed this, and we've begun data analysis. It was a 40-participant trial, 20 people active, 20 placebo, and then we had 10 crossing over from the placebo into the active treatment group. Interesting about this trial is that what we saw when people were given vagus nerve stimulation, auricular vagus nerve stimulation, so stimulating at the ear, twice per day, was that we failed to reach between group significance in the primary outcome. So people improved a little, but they did not improve more than the placebo group. However, when we dug into our subgroup analysis, where we started to understand, okay, well, who's responding and why, we saw some very interesting things. The first thing that we saw was that an inflammatory cytokine called IL-10, the amount that changed in the active group was predictive of who responded the most. So the people who were the strong responders to active vagus nerve stimulation had rapidly changing IL-10 levels, which was not seen in the placebo group. The other thing that was really interesting was we took saliva from patients participants in the trial, and every person in the active vagus nerve stimulation treatment group showed down regulation of pro-neuroinflammatory proteins, whereas in the placebo group, they actually showed the complete opposite, upregulation of these proteins. So what we take away from this is so vagus nerve stimulation did not work at the dosage that we tried, but given the physiological data that we saw in the responders, perhaps we need higher dosages. Perhaps we need to identify patients more carefully with regard to who is showing high levels of IL-10, who is showing high levels of other pro-inflammatory cytokines. So it gives us a clue as to who vagus nerve stimulation might work in, which is what we're always looking for. We're looking for clues on what is going to be most effective in which members of the population. Also, just a quick look at our Sana Health clinical trial. This is a wearable device that has been has shown really strong results in placebo-controlled, randomized controlled trials for chronic neuropathic pain, so chronic nerve pain. And so we're now trialing it in people with chronic Lyme disease and their chronic joint pain. It's a placebo-controlled, randomized controlled trial. It is completely decentralized. So if you're anywhere in the United States, we can mail this thing out to you and we can study. Our recruitment goal is 30, and we're currently about 50% of the way through. Our antiviral clinical trial, where we're looking at the use repurposing HIV medications. You can get randomized into Maraviroc, placebo, or Truvada in this particular clinical trial. We're currently targeting people with long COVID. We are still recruiting. We're actively going this trial. Our recruitment goal is 90. Actually, we have about 50 or so active or completed participants now. That number there of 30 is outdated. Moving into lumbrikinase. This is a really interesting compound. Lumbrikinase is a compound that breaks down fibrin, which is a protein that can cause clotting or clumping together of red blood cells and other cellular debris in our blood vessels. Now, in both ME-CFS, long COVID, and chronic Lyme, the work of Riccia Pretorius and others has shown that individuals may have accelerated laydown of fibrin, and they may have accelerated production of fibrin, which leads to these sort of like propensity for sticky sort of fibrin amyloid clots to form in the blood vessels. So we really want to test this, and we want to test the ability of a compound like lumbrikinase to break it down. So in this trial, we're doing an open label clinical trial where we look at the ability of lumbrikinase to break down fibrin in people. So when we say open label, this means there's no placebo. People are taking the medication, and we're looking at different dosages at the ability of lumbrikinase to break down fibrin. We're recruiting anyone with chronic Lyme disease, ME-CFS, or long COVID. And we're still recruiting. Our recruitment goal is 90. Oh, this is an old number as well. We're at about 25 active or completed participants. So we're still really trying to recruit for this one. And this one's been a bit slow, but it's a really exciting clinical trial. On to rapamycin. Low-dose rapamycin is a really interesting immunomodulatory drug. I know that this is a drug that has been getting a lot of play in the media of late. Because in addition to maybe being helpful for infection-associated chronic illnesses, it's also, I think, it's being viewed as a longevity drug because of its action on mitochondrial function. In this particular trial, we're recruiting first people with long COVID, mainly because we had limited funding, and Cimarron Research was already doing a randomized controlled trial in folks with ME-CFS, pre-2020 ME-CFS. So we want to make sure that we're covering as many bases as we can with the chances that we have. It's a placebo-controlled randomized controlled trial. Our recruitment goal is 80. We're about 40% recruited, so we're really making some progress here. Supplemental oxygen therapy. This is something that anecdotally a lot of people with long COVID and ME-CFS told us really helped them, so we wanted to look into it. So we're currently working with an air compressor using supplemental O2. So basically, this is very simple. It's open label. People who come to our clinic for physical therapy who are interested in trialing it will get nasal cannula with the supplemental O2. We give them about 2 to 4 liters of oxygen prior to their physical therapy session. We currently have data from 16 patients, some of whom have done multiple interventions with the supplemental O2. And we're currently just asking folks what their impression of the O2 is, and they do get a slight but noticeable boost. Our physical therapists are also noting that they can work the patients harder in the therapy sessions without a greater risk of post-exertional malaise. So overall, we're seeing some weak but noticeable changes in the use of the supplemental O2 therapy. The final thing I want to talk about is Venella. This is an interesting probiotic medication that we're trialing in an open label trial to address mitochondrial dysfunction. This is a supplement that breaks down some lactic acid and converts it to short-chain fatty acids, which are things that our body can use for energy quite efficiently. So we're trialing this out in an open label case series. And so it's available to our core patients based on our physicians making a decision as to whether or not someone might be a good candidate for it. We have data from 20 patients, and we're actually just in the process of doing the final analysis on this, and we hope to get a little paper out shortly. All of this is to say we have so many targets. The future here is very, very bright. We're not out of ideas by any means. We have a lot of really exciting clinical trials in the pipeline. Some of you may have seen that we just released a case series on combination antivirals that was very, very positive. So the main takeaway to patients here is we have never had more ideas and more targets than before, and we're getting a lot more sophisticated in our approaches. I also want to shout out to the fact that our clinician manual for managing infection-associated chronic illnesses is now out. If you pop in this URL, it will take you to a point where you can freely download it for anyone. Providers, patients, anyone can download it. I just want to thank all the wonderful people who help us at the clinic, and I will leave it there. Thank you, everyone. You're muted, Trudy.
Thank you. I'm sorry. David Systrom, you also have a short presentation for us.
I do. So maybe before I take a little deeper dive into the PowerPoint slide presentation and make a couple of comments. First, a nod to David Putrino. His work is seminal. He is helping lead the charge, of course, globally on diagnosis and treatment of both ME and long COVID. And he hits on several points that I think have been raised as potential larger questions as part of this webinar. One is, how do we convince the unconvinced, the naysayers, and the medical establishment across the world that these are really real diseases? And how do we treat them? Those are the two, that is the holy grail, I think, those two things, making firm diagnoses and treating hopefully in the end with precision medicine that works. So with respect to diagnoses, many of the outcome variables that David has reviewed and that I'll present briefly here in a second really do help inform the disease. So in a strange way, if we come up with treatments, biologically plausible pathways, and we intervene and we treat patients with ME and long COVID, and it works, and we have outcomes that are measurable, then in a strange way, what we have done is proven that this is an organic disease, or these are organic diseases. They are not something that is in one's head, meaning purely psychologic, and they are not simply a feature of deconditioning. These are two things that are out there I hear all the time from patients who are frustrated with medical establishment. So I think clinical trials and their outcomes can both diagnose the patient and then essentially prove that it's a real disease if we have outcomes that get better, of course, including the patient's symptoms. I think this is wonderful work that David Putrino has put out there, and what I'm going to show you will be a little shorter version. We have a lot of overlap, though, in our thinking. He and I have compared notes in Stavanger and in Berlin over this past spring. I would suggest to you that much of the thought about pathogenesis, meaning how these diseases work and cause symptoms, for both ME and long COVID, they're shared. There are a lot of commonalities. In large part, what we're talking about is an initial infection, not always with ME, of course, but many times, and always by definition with long COVID. Then unbridled autoimmunity, much of it non-specific, not classic connective tissue disease, but many patients having markers of upregulated immune systems that are dysregulated, and then resulting inflammation. And then finally, in terms of the pathways that lead to symptoms, I think we have evidence that autoimmunity and associated inflammation do things like cause dysautonomia. There's some nerve problems. I'll touch on those. Autonomic nervous system is dysfunctional. And even the mitochondrial dysfunction that David mentioned, that we also are working on, can be the result of unbridled inflammation. So with that as a background, I'll touch on a couple of the clinical trials we're doing at the Brigham in Boston and Harvard Medical School. So here's an outline of what I'd like to tell you about. First, two drugs that we are focused on. This is another general comment, perhaps. In terms of treatments, the most readily available drugs are those that are, in at least our country, FDA approved, and then physicians can prescribe them in an off-label fashion, meaning they're not indicated specifically for ME or long COVID, but they have proven with preliminary data to be useful. So this is true of the two drugs that I'm going to talk to you about now. That's pyridostigmine, also known as Mestinon, and low-dose naltrexone. Pyridostigmine is FDA approved for myasthenia gravis. It increases acetylcholine in the neural synapse at the end plate of the motor neuron. In ME and long COVID, I'm going to show you what we think is the potential helpful pathway that is facilitated by Mestinon. And then high-dose naltrexone is FDA approved for drug addiction and alcohol dependence. Low dose is likely a very different animal It's anti-inflammatory without immunosuppressing patients. And I'm going to tell you a little bit about 2 studies that we're doing that are using these 2 drugs. So first, a little bit of a primer on pyridostigmine. This is how we think it works. We had a randomized clinical trial using an invasive exercise test that I'm not going to get too heavily into right now, but I'm happy to answer with Q&A, that showed acute doses of mestinon actually improve some of the systemic blood vessel abnormalities during upright exercise. And specifically, what we showed was a single dose of mestinon versus placebo resulted in increased preload. That was a result, we think, of venoconstriction. The big veins in the body squeeze down more properly, as they should, during upright exercise, facilitating the movement of blood out of the legs and the abdomen up to the right heart, where it can do its thing. And we think the way it works is right here, and it's at the sympathetic ganglion, where it increases acetylcholine in the synapse, and then there's a nerve that, or multiple nerves that flow out of the autonomic ganglion that are sympathetic in nature, and they can help squeeze down blood vessels. So to back up just a little bit, we have a lot of evidence in both ME and long COVID that blood vessels are abnormally relaxed, both on the venous side, failure to venoconstrict, and potentially on the arterial side as well, where they lead to problems with oxygen delivery and extraction by the exercising muscle. But this is how we think mestinon or pyridostigmine may work in ME and long COVID, facilitating blood flow throughout the body on the systemic side. Low-dose naltrexone, I'll just show you a little summary of some of the purported mechanisms of action. We know it's a mu-opioid receptor antagonist. As I said, it's FDA approved for alcohol and opioid use disorders. In low doses, which are about 1/10 of the FDA approved doses for these disorders, it is interesting. And a group at Griffith and Australia has shown, put on the map, that natural killer cell function is actually restored in ME-CFS. There's likely a similar story in long COVID. So it helps innate immunity, which is obviously attractive in these diseases. And at the same time, it tamps down inflammation, not exclusively, but largely through the toll-like receptor number 4, downregulating something called NF-kappa B, which is one of the centers, as it were, for increasing inflammatory cytokines. So it tamps down inflammation without immunosuppressing patients. There's precious little out there in terms of clinical trials. There's a fibromyalgia paper reported 3 years ago with improvement in pain. This was open label. And then a Finnish study back in the day with self-reported responses of symptoms and brain fog that suggested improvement, again, open label. So we've taken 2 approaches to determine whether these 2 drugs are of use, either alone or in combination. And in the clinic, anecdotally, we've had luck using the 2 together. There may be something special about augmenting the autonomic nervous system and tamping down inflammation together. So something we call Baby Lift. This is a retrospective study using a non-invasive exercise test as a primary outcome. We looked at patients over a year on average using one of these 2 drugs, pyridostigmine or low-dose naltrexone, either alone or in combination, and the effect on something called heart rate recovery. So this is the test that we use. It's a non-invasive 3-minute test called the SHAPE. We use a metabolic cart. This is staged. 2 of our respiratory and pulmonary physiologists. It's self-paced. Even patients with orthostatic hypotension or intolerance can hang on and pace themselves over 3 minutes. And then a variety of pulmonary gas exchange and ventilatory variables are measured over the 3 minutes. And in particular, what I'm going to focus on is one called heart rate recovery after cessation of exercise. And this is what we found. This is heart rate recovery 1 minute after stopping exercise. And for those who haven't heard about this one, it's pretty ubiquitous. It's measured with wearable devices. And when one stops, the healthier the individual, as it were, the more parasympathetic tone. David talked about vagal nerve stimulation. This is a similar thought. More parasympathetic tone is good. Unbridled sympathetic tone is bad. So the faster one's heart rate decays after acute exercise, the healthier one is. So this is the heart rate recovery. The faster the recovery, the better, meaning up is better. This is mestinon plus low-dose naltrexone in 57 patients at about 1 year out with ME-CFS. You can see statistical significance. We didn't have enough yet in this study of low-dose naltrexone to make much of a comment here. Not much of a change with a small number here. And here's mestinon monotherapy with improvement of heart rate recovery. And then these are patients who received no drug. These were generally healthier patients. It's one of the pitfalls of a retrospective study here. They are better at start, and they didn't change much with exercise or with, a year of treatment. All right, so with this as a potential reason for moving forward with these two drugs prospectively and with a placebo-controlled study, we've embarked on something called the LIFT study. This is funded by Open Medicine Foundation, so a special nod to Linda Tannenbaum and her crew who has funded this to the tune of $2 million. So here's the protocol. This is a large single center study. 160 patients are targeted. We have 4 groups, one of them with combined pyridostigmine and low-dose naltrexone, another with pyridostigmine and placebo, another with low-dose naltrexone plus placebo, and then placebo, placebo. So 4 groups, all equal. Everybody's blinded. Nobody will know what patients got until the end. And then it's a 3-month study. It's non-invasive. I'll show you some of the outcome variables here. This is the dosing regimen. If one is interested, we target pyridostigmine 60 milligrams 3 times a day. That's escalated over 4 weeks. And we target low-dose naltrexone 4.5 milligrams per day, which is also escalated to that dose over 4 weeks. We've had a lot of luck with that. We have the ability to decrease if we have to. We are now at patient number 40. I borrowed from David Putrino, who's had fabulous luck recruiting in New York City with social media. We just got approval from the Harvard IRB to use social media to recruit, and I'm hoping that will accelerate this. But we're at 40 patients, about a quarter of the way through this study, so I can't give you real outcome data yet. So here are some of the outcomes that we're using. One is a Garmin wearable device in all patients done throughout the 3 months. It measures a variety of physiologic variables. So if a patient unfortunately has a crash in the middle of the 3 months, we hope to catch some of that. If they get better, we hope to see what physiologically gets better. We have a variety of omics. David mentioned some of those, and we're covering, I think, the landscape there with proteomics, metabolomics. Not shown as transcriptomics. We're getting peripheral blood mononuclear cells to Maureen Hansen at Cornell. We've got a variety of well-validated and automated questionnaires that capture post-exertional malaise, fatigue, brain fog, and others. So thanks to folks all that. And then we're doing the shape test. That's the little exercise test that I showed you a second ago at the beginning and at the end. So that's what we've got. We're excited. I think this is just an example of many. I'd nod again to David. We've got randomized clinical trials with repurposed drugs and other devices and other modalities, all of which are designed, obviously, to find helpful medications, if not a cure in the end. I'm equally excited with Dr. Putrino that we're on the cusp of learning a lot more about these diseases and effectively treating them. So I'll end there and thank you very much.
Well, thank you very much, both of you. It's very interesting to see. And I think I can say for everyone listening here that it's absolutely wonderful to see that there are clinical trials going on with a hope of actually getting some kind of treatment that can not necessarily cure, but actually make our lives a little bit better. One of the questions that I had for you, and that's also come into the Q&A, is that when can these treatments possibly come to the point where they benefit patients? Because we have seen before in ME-CFS particularly that there has been a lot of really promising but very small clinical studies, and they have never been replicated. And for instance, in Norway, we have a public health system, which is very strict on approving treatments for patients. And some of them say that we'll have at least 2 RCTs, large-scale ones, before we can approve this. So how do you see this working?
So, I think it's a really fair comment and concern. I think the impetus behind us releasing the manual of what our practices are at our clinic were very much to share a lot of the protocols that we have found helpful, because, as we all know, there are no FDA-approved drugs for long COVID. There are no FDA-approved drugs for ME-CFS. When we think about chronic tick and vector-borne illness, forget it. We can't even get regulatory agencies to acknowledge that these very real conditions exist, let alone have FDA-approved treatments for them. So the reason we released the manual was because we need providers to step up and be willing to provide off-label interventions based upon some of these well-conducted, if small, studies. So for instance, one of the things that we have in the manual is a recommendation to at least trial H1 and H2 blockers in people with ME-CFS and long COVID if there is a suspicion that mast cell activation syndrome could be at play. And we cite, a placebo-controlled RCT that uses famotidine at 40 milligrams twice per day, that improves cognition in people with long COVID who were reporting cognitive impairment. So there are treatments out there, and they do require physicians to be up to date with the literature and follow what the literature is saying, even if the medication or the supplement is not yet FDA approved. I know that in certain countries outside of the United States, it's harder to do that with medications, but there are still many supplements that are well researched that providers can prescribe, even in places like Norway, that can make a world of difference. Things like oxaloacetate in a subset of patients can make a world of difference to patients. And what we really want is for providers to be aware, so at the very least they can do a little with what they currently have and where the literature currently is.
Yeah, I'd agree totally with David. I've actually locally and probably nationally, globally, seen the needle move some. And, this is over the 5 years of long COVID and 10 years I've been doing ME-CFS. I remember a decade ago, there was a lot of skepticism about whether ME was a real disease. And this was from really well-trained, informed colleagues down the hallway who kind of knew a lot of the cardiopulmonary physiology that we've helped put on the map in ME and long COVID. And then very similar at the beginning of the pandemic and first descriptions of long COVID. Now, we are finding, and this is, I think, one of the bright lights that David alluded to, we have a system in place where we'll complete this LIFT trial that I just presented, so 2 off-label drugs. And then we go to the primary care physician toward the end of the 3-month trial, and we say, okay, your patient, we don't know what they got, but they survived our study. In fact, more than that, we've had, I didn't say this, 2 dropouts out of the 42 patients, 40 completed or almost completed. Your patient seemed to do well in this study, certainly didn't do poorly. We've had a lot of luck with these 2 drugs in the clinic, and here's how we do it. And it's similar to David's manual, although focused on the 2 drugs. And I've been really surprised, in a sense, at how the frequency at which the primary care physicians are putting their hand up and saying, we will embrace this. The whole notion that this is a real disease and that you've got off-label drugs that seem to be helpful. So I'm willing to step up, even though I don't know anything about pyridostigmine or low-dose naltrexone. I'm learning from you, and I'll step up and we'll do this ongoing. So that is hugely different from a decade ago, and very different even from 5 years ago.
It's very good to hear that you see this kind of development. We also find that it's the primary care physicians who are usually seen as most competent when it comes to ME/CFS by patients. But in a survey, we had around 50% of ME patients were happy with their primary care physician. Contrast that with 80% of the rest of the population. And those who were happy with their physician had usually changed their primary care physician 2 or 3 times before they found someone who were actually competent and willing, for instance, to try out off-label treatments like LDN. There's quite a lot of people here finding it very hard to even access low-dose naltrexone, and not to speak of some of these other things. So how can researchers and the patient community together try to educate the primary care physicians? Do you have any thoughts about that?
They've got to get out there and they got to get out there and do it, right? I run at Mount Sinai. I run 6 centers. Each center has its own clinical focus. So the Cohen Center, the core, is one of 6, and we always have different pillars in each center. We have a clinical pillar that we think about. Like each center, we want it to be strong on clinical knowledge. We want it strong on research ability and research knowledge. We want it strong on innovation, looking for new cures, looking for new ideas. And then the final pillar is always education. Because, we think about it from a growth mindset standpoint of, we're in New York. New York has very little free real estate, which means that any clinic that we run is going to be tiny. And it's not going to, even if we're the best clinic in the world, it's not going to be able to scale to the millions of people who need the care that we're providing. So education has to be at the forefront of every long COVID researcher's mind. It's not just, what is the research that I'm doing and how am I going to get my next grant? I'm sorry to say, you also need to be thinking, how am I disseminating this knowledge to the millions of, primary care, the thousands of primary care providers, PCPs out there who, this was not a part of their training. In fact, their training told them to dismiss these patients as psychological patients. That is the absolute reality. That is what was taught previous to this. So, we have, of course, we've released the manual that has been downloaded more than 7,000 times now. We have been doing events all around the United States where we provide either in person or online, where we sit down specifically with primary care providers, because primary care really, to me, is the specialty where someone walks in and says, I don't know what's happened to me, but the last 8 months I haven't felt right. Maybe it was an infection, maybe it was something else, but I'm fatigued, I can't get out of bed most days, et cetera, et cetera. they're the people who are at the front line who need to be able to identify, I think you have ME. I think you have long COVID. I think a tick bit you and you've never fully recovered from that. They're the folks that need the education. And at this point, at this stage, we've provided educational materials to over 2,000 PCPs in the United States. But that's a drop in the ocean. The work isn't done, and we need to keep providing guidelines. I firmly believe that the majority, the vast majority, there will always be exceptions, but the vast majority of medical providers out there want to help. They just don't have the tools to help. It is incumbent upon us, the researchers who are uncovering the new knowledge, to give them the tools, and give them the tools in the easiest digestible form that they can go straight to implementation.
The manual you're talking about, I'm sure you will provide me with the link to it, so I can put it in the comments when I put this video up online. David Systrom?
Yeah, I saw a couple of questions in the Q&A related to mestinon and low-dose naltrexone. One was, how have they been tolerated? I'll give you my view. David may have some comments. Mestinon generally well tolerated. If there are symptoms or side effects, they tend to occur early and then strangely go away, even though some of the good effects persist. The major categories of side effects are GI, diarrhea in particular, maybe nausea if one takes the medication on an empty stomach, so avoid that. And diarrhea, if it happens, we'll treat with Imodium for a few days and it generally goes away. Once in a while, we have to reduce the dose. I'll come back to the dose. The other one is muscle cramps, which many patients have even before we give the medication. We'll use chelated magnesium oxide, usually 400 milligrams per day, if that's a problem. And again, that one usually goes away. We begin mestinon at 30 milligrams 3 times a day for 2 weeks. And then we will, if all goes well, we'll escalate to 60 milligrams 3 times a day. There is an extended release version, but its absorption from the gut, the GI tract, may not be as reliable as the intermediate release. With respect to low-dose naltrexone, side effects are generally few. One interesting one is intense dreams or nightmares. So if that's taken in the morning, not in the afternoon or evening, that's largely avoided. Occasional patients will notice worsening of their underlying symptoms, things like fatigue or brain fog transiently, and then they get better if they're able to stick it out. We generally talk about 6 months of low-dose naltrexone as the minimum amount of time to assess efficacy. The Scandinavians have educated me. There are those who believe the initial mild worsening of symptoms is actually predictive of a better response to a low-dose naltrexone eventually. So I think that covered side effects and dosing. But we escalate both. I didn't mention the low-dose naltrexone. We start at 1.5 milligrams per day. That's 2 weeks. Then 3 milligrams a day for 2 weeks. And then we escalate to the final 4.5 milligrams per day. And most of the time, patients are fine with that.
In either of your trials, are you including the severely ill? So people who cannot come into the clinic?
Yeah. For our LIFT trial, we cannot do patients who are homebound or bedbound, unfortunately. We'd like to do that, but the outcome variables, including coming into the hospital for blood urine collection and the shape test that I mentioned, the exercise test, requires some in-person visits. So we do moderately ill patients, but if they're homebound or bedbound, unfortunately, right now the protocol doesn't allow their inclusion. But I hope by extrapolation, these drugs can be used in those settings as well.
Yeah, we many of our research studies, so not interventional clinical trials, but research studies, we provide participants with the option of participating from home. So we send a nurse to their home if they're too unwell to make it to the clinic, and we take samples, the necessary samples from the home environment. Largely because we did want to make sure that folks who are very, very severe or severe are able to participate, because, you know, we think that if we're searching for biomarkers, this is a cohort that is going to have some of the most obvious biomarkers that we may be able to identify. We also have a couple of clinical trials similar to David Systrom's situation. There are some trials that we have failed as yet to decentralize. We're always looking we're looking for more accessible ways to decentralize some of our trials, but some simply cannot be decentralized because some of the technology is location-based and we can't change that. However, we do have a couple of open clinical trials where, such as the supplemental oxygen trial, as well as a trial that will be IRB approved soon, looking at blood flow restriction therapies for folks with long COVID and ME-CFS, where home visits for very severe will be available. We acknowledge the lack of trials that include folks who are very severe, and we're always looking to change that.
Yeah. You know, we have done quite a few large-scale surveys in Norway, and we generally find that around half of the patients are housebound or worse. So there will always be a large portion that cannot come into a clinic regularly or has a predictable level of disease, which means they can participate. And those are the people who are most in need of treatment. So I think it's very important to reach those people with clinical trials as well. So I'm hoping that you'll find a way to keep doing it in the future. One thing I'd like to address is, as I said earlier, we've seen far too few clinical trials in ME-CFS or long COVID, even though long COVID is getting a lot more attention than ME-CFS. We've seen too few studies at all in ME-CFS. And I think that has also to do with how politicians, healthcare, and so on view these diseases, that it's, you know, just a little bit malingering at times. And how can we convince those people who give the funding to, for instance, realize the very real increase in patients after the pandemic, and how important it is to find answers both to the causes of these diseases, but also treatment and getting people actually back into work and into normal lives? How can we do that?
I mean, one thing that I would say on that front is that I think it comes down to education again, and clear messaging. The literature already exists. We don't need to talk about ME-CFS and long COVID as though they are these mysterious illnesses. We also don't need to talk about them as though they're contested in whether or not they are biological or not. These are biological illnesses, and, you know, not even lying to curry favor with David Systrom on here, but David Systrom's work is often some of the work when I'm talking to policymakers, where I will show the invasive CPET work in ME-CFS and long COVID and say, look, this is what heart failure looks like, you know, and these folks are different from healthy controls. I will show Rob Wust's work and I'll say, look at the differences that we are seeing in muscle biology in people with long COVID and ME-CFS. And so these are beautifully constructed trials that are published in some of the highest profile journals that exist, showing biological changes associated with these illnesses. So it's less about needing the research, and it's more about utilizing the research that we have. You know, Michael Peluso showing incredible, data around viral persistence and circulating spike protein in people with long COVID. The work that we have done with Akiko Iwasaki showing immune dysregulation both in ME, pre-2020 ME, as well as long COVID patients. These are the sorts of studies that already exist. They're already published in Cell and Nature, and what we need is a coordinated repeating of these facts over and over again, because there is a certain point where anyone who is arguing against these facts become fringe scientists. And I think the problem with ME is that for 30 years, there has been a very powerful lobby talking about how these are illnesses that are functional. These are illnesses that are psychological. And now what we need to do is show that with enhanced techniques and better research acumen, we've been able to show that these are in fact biological illnesses without a shadow of a doubt. The research is already out there, the evidence is already out there, and we need to just keep repeating that now.
Yes, and I also sometimes think that we need to put the research into language that can be understood by people who are not researchers, so that we can take it, for instance, to politicians and have something that has a good argument. But it's very difficult because they will say, well, I saw this other study that showed that people who had thought differently became well. And it's very hard then to start to argue, because you have to go into the actual research and what it shows, and it gets very technical, and that you lose them. So how to meet those arguments? And I think we really need to get researchers and patient community together to work on getting information that's easy enough to access, but also has all the right facts. So
I agree.
A challenge for you.
No, I agree 100%. And I agree that also knowing the research means that you need to know, you need to know how to also rebut in an understandable way some of the research that has emerged that is poor quality, but but works in opposition to the fact that we're dealing with biological illnesses. And so we always do try to come prepared with that, because it is a very it is a very desirable outcome for governments to be able to say these are just psychological conditions and we're not going to address them properly. And so we always need to be very well prepared to rebut that.
I would say on the topic of political buy-in, there are examples of orphan diseases, and of course ME and long COVID don't qualify as orphan. The numbers are staggering, but that have received, at least in the past, federal funding in the United States, largely because some congressman has a sick relative with said disease, unusual disease. So I think one of the so-called silver linings of long COVID is that so many people have been affected and acutely and linked to, of course, the acute COVID event. And there's been that kind of line of thought. So there have been politicians who have either been directly affected or had family members affected, and that's helped open some of the willingness to open the purse strings and fund research and all these things. So that, in a strange way, when it gets personal, politicians can come around.
One last question, bordering a little bit on that. David Putrino, you talk a lot about infection-associated chronic diseases or illness conditions. But then you also talked about, in one of your studies, finding subgroups on the vagus nerve study, where different people within the same disease actually had different results. To which degree should we talk about this group of diseases all together in order to get funding or interest? Or how much should we actually try to split them up? Because there may be subgroups.
Yeah, this is a hot topic. I think it's an important topic. You know, the way that I think about it and the way that our clinic thinks about it is there are clinical goals and there are research goals. Clinically speaking, the reason that we started adopting the term infection-associated chronic illness as an umbrella term to cover many diagnoses is because there are many similarities and differences that exist with the different diagnoses, but it is helpful to group things together, you know, that maybe have some similar mechanisms behind them from a clinical standpoint to make sure that people are not left behind. So, for instance, when you look at the National Academies of Science, Engineering and Medicine and their clinical case definition of long COVID, they were extremely expansive in their definition of long COVID. So a lot of things could be considered long COVID, so long as the change in health status could be tied to a COVID infection. But then what they also did, and they were very careful to state, was in research, we're going to need to become highly specific about subtypes because we're casting such a wide net to make sure that people are not left behind when it comes to care. So that's how we adopt a similar process within our clinic, which is we don't much care what the diagnosis is, so long as we think that there is a link to an infection-associated chronic illness. And then what we're going to do is we're going to assess you very deeply to try and understand what is driving the symptoms that you're experiencing. Is it viral persistence? Is it autonomic dysfunction? Is it mitochondrial dysfunction? And we'll give you targeted, personalized therapy based on our assessment findings. But from a research standpoint, we can and must separate people as clearly as possible with the methods we have available to us to maximize the chances that clinical trials will be successful. For instance, you know, something maybe a situation that David Systrom is probably more qualified to speak on than me, but you know, if you think about pneumonia, right? You could say all pneumonias are alike because the person comes in, they've got a chest X-ray that will look pretty similar, you know, with a couple of examples to the contrary. David's already rolling his eyes at me, but they will have low oxygen saturation. They'll be short of breath. They'll have difficulty breathing, and they'll be coughing up phlegm, right? Now, it would be crazy for us to say that all pneumonias are the same because of that, and therefore everyone should get the same drug because of that. That wouldn't work. You know, in many, many cases, it really does depend on what drug you're giving the person, and does it match what is growing in their lungs as to whether they will get better or not. You know, so something like Legionnaire's disease, you're not going to benefit from a broad spectrum antibiotic. You need a very specific antibiotic to treat that. So to that end, that's how I think about infection-associated chronic illness. It's helpful to have a framework with a broad umbrella, but then we must, for effective treatment, start to subgroup people and understand, you know, what long COVID subtype A, B, C through Z looks like, and what are the targeted treatments that we need. What is ME-CFS subtype A through Z, and what are the treatments that are going to be helpful? And we've seen, you know, similar research showing this over and over again. You know, in Stavanger, we saw the work with the B-cell therapies, where only individuals with ME-CFS who had a high natural killer cell count responded to the B-cell therapy. So that tells us something about a subset of people with ME-CFS. And if you want continued successful clinical trials, you need to pay attention to those subsets.
One thing that I'm curious about is a little is that at the pandemic, everyone tested themselves every time they had an infection to see if it was COVID or not. And it's easy to confirm that something is long COVID because you had a positive test in the weeks before. At least in Norway now, we've come to a situation where people just accept that they get ill a couple of times a year, more or less, and no one uses tests anymore. So if you get ill, you have no idea whether it's COVID or flu or whatever you had before. So is it going to be very difficult to differentiate ME patients with a different trigger from people who have an ME-like illness triggered by COVID in the time coming?
Yes, I think it's a massive public health failure that we have stopped testing and we have stopped attempting infection prevention. To my earlier comments, I think it's going to massively hurt research efforts because we're not going to know what triggered the illness, and therefore does this person have an infection-associated chronic illness that was triggered by an enterovirus or norovirus or flu, or do they have something that was triggered by COVID? My hope is that as we get, folks like, to name another brilliant David, other than David Systrom, because that's getting tiresome, David Walt, also at Harvard. There must be something about Harvard. They seem pretty good. Who's doing these spike assays using Simoa. This is the sort of research that is going to become really, really important. Our ability to identify circulating pathogen in the body that might give us a clue as to what was the triggering event, or at least what is the pathogenic driver of illness, if there is a pathogenic driver, or is it something else? Is it mold exposure? Is it heavy metal exposure? Is it, chronic inflammation? Is it autoimmunity? What we need is a new generation of tools that will allow us to identify, because we've really failed in testing for things. And I always come back to what would you do if your patient can't talk to you, which always brings me right back to what do vets do? When your dog is sick and you go to the vet, they test for everything, right? The dog seems a little bit unwell. Okay, they're going to take a bunch of cultures and biopsies and they're going to test, right? And we don't assign that similar level of intellectual curiosity or, interest to what's happening in humans. So what would be wonderful in 2025 is that when you get sick, you do a nasal swab, not just testing for COVID, but for a bunch of viruses, a bunch of bacterial infections, so that you can know what made you sick at the point of you getting sick. That way, if you do have long-term sequelae, we know what to call it, we know what to assign it to, and then we can start the process of intervention from a much more informed place.
We're actually 5 minutes beyond the hour already, but if I could ask just one little question at the end, a little question, it's actually a huge question, but if you should speculate on the field of ME and long COVID, where do you think we will be in about 5 years' time? Should we start with David Systrom this time?
Yeah, I think I would echo David Putrino's earliest comments about how these are incredibly exciting times for the field of ME and long COVID. I think the field has moved forward at an exponential rate. I can look at a bunch of seminal studies over the past year to year and a half that I think have totally moved the needle. So I think it would be, I don't want to speak for the other David, but I think it would be our mutual hope that we do everything that was just talked about. We identify subtypes of patients, their pathophysiology, what underlies their disease and their symptoms, and we effectively treat them. So I would hope that at the end of 5 years, we have made a giant leap forward in treating large numbers of patients effectively.
Yeah, I I couldn't agree more. I mean, I think that in 5 years, where I hope we'll be, and when I look at some of the work being led by folks like the Polybio Research Institute, I get a lot of hope that we're heading this way, is rapid sequencing and phenotyping using advanced technologies of people living with infection-associated chronic illnesses. And we are seeing, we're seeing David Walt with Samoa, we're seeing Francis Lee Yoon with Mensa technology, we're seeing the folks at JCVI who are doing all sorts of amazing sequencing data and reverse transcriptomics and all sorts of amazing techniques that allow us to understand, is a pathogen there and is a pathogen causing trouble? I really, really hope that in the next 5 years, that is going to be applied to precision medicine approaches in infection-associated chronic illness. I always come back to, in 1978, Susan Sontag wrote a book, Illness as Metaphor, and she wrote the book shortly after she had been diagnosed with cancer, and she had been told, you got this disease because of your personality. Yeah, cancer personality. And that's why you got cancer. And she had a lot of anger about that, rightly so. And so she wrote this book about how we metaphorize illnesses that we don't understand. And what we've seen is from the writing of that book to 2025, we've gone from people being told that they have cancer because of their personality to when you get diagnosed with cancer now and you're at Memorial Sloan Kettering or some high-level cancer hospital, the medications that you receive will be different based on your personal genomics, your personal biopsy from the tumor that they took from you. Everything is personalized to you. And what I hope for IACIs is that is the path that we're on over the next 5 years, is every single individual is given personalized care based on what pathogen triggered the thing, what other exposures have occurred that could have worsened the illness, what is your inflammatory status, what is your autoimmunity status, really starting to move toward precision and personalized care.
Well, thank you, both of you, so much. I think what you have been telling us has given me, at least, and I hope everyone else, a lot of hope for the future. I've been ill since 1999. And I'm also impressed with the number of publications coming out of the last year that's actually changing the field. It's gone from being very marginalized to being at least moving slightly to the center, but it's still a long way to go. But I hope you're right, and that 5 years will see huge differences. So with that, thank you again for joining us. And we wish you all possible luck in your future work. And thank you for doing it. I think I can say for the whole ME community, the researchers that work in this field are our heroes. And we appreciate you very much. So thank you.
Trude, and
thank you so much.
Want to thank you as well. I mean, what you're doing is hugely important, and that's getting the word out and helping us get the word out. So really appreciate it.
Thank you.
Totally agree.
Okay. Goodbye.
Cheers.
Thank you. Bye.